Good day. The topic to be discussed is Philhealth. The following is an outline of this presentation. The Philippine Health Insurance Corporation, or Philhealth, is a tax-exempt government-owned and controlled corporation that deals with health care financing and is attached to the Department of Health. It aims to provide quality health care for all Filipinos by ensuring a sustainable national health insurance program for all. In line with the vision mission of Philhealth, all strategic plans and objectives of the corporation shall be anchored on the new Philhealth vision and mission statement. A short history of Philhealth will be discussed. The call to serve the rural indigents echoed since the early 60s. The Philippine Medical Association introduced the Maria Project, which provided physicians to rural areas without doctors. After years of public pressure for a national health insurance plan, the government under President Marcos enacted the Philippine Medical Care Act of 1969 that was implemented on August 1971. It was to provide for a comprehensive medical care program that will be introduced gradually. Program 1 was to be put into effect on January 1972. It was to cover private and public wage earners who are insured under the Social Security System and the Government Service Insurance System respectively. Program 2 was to cover eventually everyone else. This was expected to become fully operational by the year 1974. The Medical Care Act will directly compensate the healthcare institutions and providers of surgical and medical services according to a fixed schedule. The Philippine Medical Care Commission was tasked to oversee the implementation of this program. In the 1990s, the passage of several bills made the national health insurance more comprehensive in terms of covered population, benefits, and health financing. These include House Bill 14225 and Senate Bill 01738, or National Health Insurance Act of 1995, that was signed by President Fidel V. Ramos on February 14, 1995. This law paved the way for the creation of the Philippine Health Insurance Corporation, mandated to provide social health insurance coverage to all Filipinos in 15 years' time. The National Health Insurance Program, administered by Philhealth, was established in 1995 with the passage of Republic Act 7875. It provides health insurance coverage and ensures affordable, acceptable, available, and accessible health care services for all Filipinos. Health insurance is not compulsory. Payment scheme for health providers is the fee-for-service, wherein physicians charge separately for each patient encounter or service rendered. Philhealth took over the Medicare functions previously administered by the Philippine Medical Care Commission. Philhealth's mandate is to provide health insurance coverage to all Filipinos, starting with government workers in 1977, followed by private sector workers and indigents in 1978. To date, all families in the DSWD National Household Targeting System for Poverty Reduction are covered by Philhealth. In 1999, Philhealth started covering self-employed and the informal sector, and in 2005, it assumed Medicare functions from the Overseas Workers Welfare Administration, or OWA, for overseas Filipino workers. In June 19, 2013, Republic Act 10606 was passed, which provides mandatory health care for all Filipinos. It ensures coverage of the marginalized by prioritizing health care needs of the underprivileged, sick, elderly, persons with disabilities, women and children, and provide free health care services to indigents. There are several membership categories: formal, informal, indigent, sponsored, and senior citizens, and the most recently added, lifetime members. Members in the formal category include those with formal contracts and fixed terms of employment, including workers in the government and private sector. The premium contribution and payments are equally shared by the employee and the employer, not exceeding 5% of their respective basic monthly salaries. Members in the informal economy include those who are self-earning and migrant workers. Lifetime members are for those who have reached the age of retirement and have paid 120 monthly premium contributions. Indigent category includes persons who have no visible means of income or whose income is insufficient for family subsistence, as identified by the Department of Social Welfare and Development based on specific criteria. Sponsored members include those whose contributions are being paid for by another individual, government agency, or private entity. Senior citizens are those who are 60 years old and above and are not concurrently covered by any of the existing membership categories of Philhealth. Philhealth coverage also extends to the immediate family of its members, which include legitimate spouse who is not a member, child or children 21 years and below, child or children over 21 suffering congenital diseases, foster child as defined by the Foster Care Act of 2012, and parents 60 years and above or parents who have permanent disabilities regardless of age. The following are the benefits that can be availed from Philhealth. This includes inpatient, outpatient, Z, and Millennium Development Goal benefits. The Philhealth member must be admitted more than 24 hours in a Philhealth accredited facility to avail of the inpatient benefits. Maximum benefits will depend on the case type of illness, services rendered, professional and hospital category, and patient's length of stay. Outpatient benefits include ambulatory or outpatient day surgeries, radiotherapy, hemodialysis, outpatient blood transfusion, and primary care benefits. The newest package of Philhealth that will primarily address catastrophic cases is called the Z benefit. This includes illnesses that push patients into prolonged hospitalization and very expensive treatments. These illnesses are listed in the table. A no balance billing or walang dagdag bayad or no payment is applicable for sponsored members, while fixed copay or fixed amount will be paid on top of the package will be applied for non-sponsored members. MDG or Millennium Developmental Goals related benefits are the diseases or conditions that are covered by the WHO Millennium Goals, which include improvement of maternal health, reduction of child mortality, and combating major communicable diseases such as HIV, malaria, and tuberculosis. I am now going to discuss fee for service. In the Philippines, ICD-10 coding has been implemented through Administrative Order No. 47, Series of 2000, which mandates its adoption in all hospitals to improve the quality of morbidity and mortality statistics in licensed hospitals and other health facilities. Also, Philhealth requires all healthcare providers to comply with the ICD-10 requirements for faster and transparent processing of claims reimbursement. The Relative Value Unit, or RVU, is a number assigned by Philhealth to a surgical procedure to reflect its relative weight or its degree of complexity as compared to another procedure. The more difficult the procedure is, the higher its relative value. For example, a simple appendectomy has an RVU of 100, but an appendectomy with associated complications such as rupture and/or abscess has an RVU of 150. Relative value units are used to complete benefit allowances such as professional fees. The higher the RVU, the higher is the benefit allowance. As shown in the table, an RVU value of 501 and above increases professional fee of healthcare provider, as well as increases operating room benefit. All medical illness now coded using ICD-10 are assigned corresponding fixed case types. Based on Philhealth Circular 18 of 2009, case type is defined as an assessment of the complexity of illness after discharge. The complexity is measured on a 4-scale system. Case type A is the least complex or simple. Example is upper respiratory tract infection. And case type D as the most severe. Example is deep intracerebral hemorrhage. For coding and reimbursement of medical claims, Case type will be based on the ICD-10 of the primary illness or main condition. Primary illness is defined as the condition identified at the time of discharge as being the main reason for the patient's confinement. For Table 1, acute pyelonephritis is a primary illness at the time of discharge. Thus, the final case type is B. In Table 2, acute pharyngitis is the primary illness after discharge. Thus, the final case type is A. For surgical procedures and other services, case type is based on the corresponding RVU assigned to the procedure. For RVUs 80 and below, the surgical procedure is classified as case type A. RVUs 81 to 200 are classified as case type B. Case type C has a relative value unit of 201 to 500. And case type D has an RVU of 501 and above. For claims with 2 or more surgical procedure, the case type shall be based on the procedure with a higher RVU. In this example, case type B, modified radical mastectomy, is the final case type. In cases where the case type for the medical diagnosis and the surgical procedure are different, the higher case type shall predominate. There are 4 hospital levels. Level 1 or primary hospital has the capacity to do routine laboratories and minor surgeries. Level 2 or secondary hospital can do general surgeries. Examples are the district hospitals of the Department of Health. Included here are the freestanding dialysis centers, ambulatory surgical clinics, and outpatient clinics. Level 3, tertiary hospitals, have the major specialties and subspecialties. Level 4, tertiary, are the teaching and training hospitals and have a highly specialized critical care unit. Reclassification of healthcare facilities was done through Circular 14 of 2013 to address inequities in health access. Philhealth strengthened its primary care so that medical illness and procedures that were currently done in a hospital setting can be treated in primary care facilities without compromising quality of care. A fixed professional fee is given based on the healthcare provider's qualification. There are 3 tiers of qualification of doctors. Group 1 for general practitioners, Group 5 and 6 for doctors undergoing training, and Group 2, 3, and 4 for specialists. For example, a specialist will get a higher compensation of 500 to 700 per day compared to a general practitioner rate of 300 to 500 pesos per day. There is a limit on the compensation of the professional fee based on qualification of doctor. In Philhealth Circular 9 of 2009, payment of professional fee of surgeons are based on the relative value unit multiplied by a peso conversion factor. The peso conversion factor is dependent on doctor category. Group 1 physicians or general practitioner will have a PCF of 40, Group 5 and 6 have a PCF of 48, and Groups 2, 3, and 4 a PCF of 56. An anesthesiologist's fee is determined using the percentage from the surgeon's fee. For an example, appendectomy has an RVU of 100 with a case type B since the RVU is between 81 to 200. If the surgery was done by a Group 2, 3, 4 or specialist, then the professional fee will be 100 times 56 or 5,600. If appendectomy was done by a physician in training or Group 5, 6, then professional fee is calculated to be 4,800. There is a cap or limit of reimbursement for professional fees depending on the level of the healthcare institution. Maximum payment for physicians in Level 1 hospital is 2,000 pesos per confinement. There is no limit for Level 2 hospital. For Level 3 and 4 hospitals, there is a ceiling of 3,200 pesos for Group 1 physicians handling all case types. For physicians in Group 2, 3, and 4 handling case type D with a relative value of 501 and above, the peso conversion factor for computing professional fees is increased to 80. In the example shown, intracranial surgery was done with an RVU of 600. For Group 1 physicians, Professional fee reimbursed will only be 3,200 pesos despite actual computation of 24,000, since there is a limit in payment for GPs. For Group 5-6, professional fee is computed using RVU multiplied by the peso conversion factor of 48, giving a total of 28,800 pesos. For Group 2, 3, 4, since the procedure done has an RVU greater than 501, then the peso conversion factor of 80 will be used. An exercise on fee for service. A 46-year-old woman was admitted for removal of myoma or undergo a procedure called myomectomy. She was confined in a level 3 hospital for 6 days. A gynecologist and an anesthesiologist, both fellows in their respective societies, were the healthcare providers. Case type of myomectomy is B with a relative value unit of 150. The hospital of confinement is level 3, so the table for level 3 and 4 will be the basis for computing hospitalization benefits. The following are the benefit allowances. For room and board, allowance is 500 per day or 3,000. For drugs and medicines, the maximum benefit allowance is 14,000 pesos. For X-ray, laboratories, and other supplies, the allowance is 10,500 pesos. An operation with a relative value unit of 150 was done, so a benefit allowance for the operating room is 3,500 pesos. For the professional fee of the gynecologist who is in level 2, 3, 4, the benefit allowance is RVU times 56 or 150 times 56 equal to 8,400 pesos. Professional fee for the anesthesiologist level 2, 3, 4 is computed with the following formula. 56% of surgeon's fee equals to the professional fee of the anesthesiologist, amounting to 3,360 pesos. Issuance of Philhealth Circular 31 of 2013 resulted to a change in the payment scheme for providers, with a shift from fee-for-service to case rate payments. Studies have shown that fee-for-service may result to increased expenditure secondary to prolonged hospital stay and unnecessary diagnostic and healthcare services, resulting to decreasing financial resources of the corporation. Case rate payments were implemented to support the universal healthcare program of the government, with one fixed benefit rate for every illness. Case rate means a fixed rate or amount will be reimbursed by Philhealth for a specific illness or case, which will include professional fee for the healthcare provider, facility charges, diagnostics and laboratories, medicines, and supplies. All case rate payment is paid directly to the healthcare institution. With the successful implementation of the first 23 medical and surgical conditions under the case rate payment scheme in September 2011, Philhealth endeavored to implement case rates for all cases and conditions. This promoted an equitable basic benefit that is the same for similar conditions, whether admitted in government or private health institutions. ICD-10 is used to code all medical diseases. Modifications were done to address uniqueness of some diseases and conditions in the Philippines. Medical case rates are identified using the ICD-10. Procedure case rates are identified using the relative value scale. Addition of procedures and services were included by Philhealth that are not included in the CPT but were deemed reimbursable in the local setting. Grouped ICD-10 codes usually have the same case rates. The Relative Value Scale 2010 is a systematic listing of surgical, medical, and diagnostic procedures and services and their corresponding 5-digit code and relative value unit. The descriptions of procedures and the codes used are mostly lifted, with permission, from the current procedural terminology or CPT of the American Medical Association. As shown, the heading, graft for facial nerve paralysis, is a common lead term being shared by the 4 modifiers under it. Thus, if referring to the third procedure with code 15842, for example, it should read graft for facial nerve paralysis, free muscle graft by microsurgical technique, RVU 260. Similarly, the fourth procedure with code 15845 should read graft for facial nerve paralysis, regional muscle transfer, RVU of 200. Rates for medical conditions and procedures were set by Philhealth taking into account the following. For medical case rates, the healthcare institution fee and professional fee is 70 and 30% respectively of the total case rate amount. For procedure case rates, the healthcare institution fee and professional fee is 60 and 40% respectively of the total case rate amount. When the patient has multiple conditions managed during confinement, healthcare provider may claim two case rates. First case rate is medical condition or procedure that used most resources in managing the patient. The second case rate is the medical condition or procedure with the second most resources used. For a claim with a combination of case rates, that is medical condition and medical condition and procedure, or procedure and procedure, the provider shall be paid the full case rate amount for the first case rate plus 50% of the second case rate. If the second case rate is a medical condition, the healthcare institution will get 20% of the second case rate and the physician will get 30% of the second case rate. If the second case rate is a procedure, the healthcare institution will get 10% of the second case rate and the physician will get 40% of the second case rate. Example A shows a medical condition, subarachnoid hemorrhage, as the first case rate, and a medical condition, acute myocardial infarction, as the second case rate. For the first case rate, the healthcare provider and health facility will be paid 100% of the total case rate for subarachnoid hemorrhage that totals to 38,000 pesos. 70% of the case rate for subarachnoid hemorrhage, or 26,600 pesos, will be the hospital fee, and 30% of the case rate, or 11,400 pesos, will be the professional fee. For the second case rate, 50% of the total case rate for myocardial infarction will be reimbursed at amounts to 9,450 pesos. The hospital will receive 20% of the second case rate, 3,780 pesos, and the health provider will get 30% of the second case rate amounting to 5,670 pesos. Total benefit is 47,450. Total hospital fee is 30,380 and total professional fee is 17,070 pesos. Example B shows a procedure, simple mastectomy right, as the first case rate and a procedure, simple mastectomy left, as the second case rate. The healthcare provider and health facility will be paid 100% of the total case rate for simple mastectomy right that amounts to 22,000 pesos. 60% of the case rate for this procedure, or 13,200 pesos, will be the hospital fee, and 40% of the case rate, or 8,800 pesos, will be the professional fee. For the second case rate, 50% of the total case rate for mastectomy, simple left, will be reimbursed that amounts to 11,000 pesos. The hospital will receive 10% of the second case rate, and the health provider will get 40% of the second case rate, amounting to 2,200 and 8,800 pesos respectively. The total benefit is 33,000 pesos. Total hospital fee is 15,400 and the total professional fee is 17,600 pesos. The following are procedures that should be paid in full even if reported as second case rate. This includes bilateral tubal ligation, blood transfusion, brachytherapy, among others. To trace the history of the use of relative value scale in the Philippines, one has to review its development in the United States. The relative value scale is a schema used by Medicare in the United States and nearly all HMOs to determine how much money to pay medical providers. In this system, three factors affect calculation of payment: resource-based relative value scale, geographic practice cost index, and a fixed monetary conversion factor. This was adopted by Philhealth to compute average cost of surgical operations. This was first formulated in 1972 and has undergone several revisions. The following table shows a comparison of Medicare and Philhealth. Both use ICD-10 and CPT codes, but for PhilHealth, there are modifications for medical as well as surgical conditions to address its uniqueness. Both also have relative value unit codes for every procedure. No geographic practice cost index is used in PhilHealth. A predetermined conversion factor is used for PhilHealth, uses the peso conversion factor, which is dependent on qualification of healthcare provider. In summary, I have discussed the history of PhilHealth, its membership categories, and its benefits. Likewise, fee-for-service and case rate payments were discussed. Case studies and examples were given to illustrate these models of payments. PhilHealth is a work in progress. It changes depending upon the needs of the population and the political climate present. The strategies for membership, enrollment, payment scheme, and benefit coverage continue to evolve, but it is encouraging to realize that PhilHealth, despite its limitation, is sincere in addressing the needs of the people. Thank you.